Hmm.
Welcome, everyone. Thanks for joining us today. Before we begin, please share your name, organization, and location, the city and state in the chat. And also, just as a reminder, we are recording the webinar today and it will be shared afterwards. And it will also be edited into a podcast for on-demand listening. I want to thank you all so much again for joining us today. I'm Sterling Katav, the Engagement, Equity, and Inclusion Associate here at Children's Health Watch. And for the past 4 years, the annual Children's Health Watch Equity Series has explored equity in various aspects. 2020's What Equity Looks Like focused on different hardships and their roots in racism and inequity, with a particular focus on COVID-19 and how that worsened them. 2021's Equity Can't Wait, Transforming Child Health Today for a More Prosperous Tomorrow, looked at how tax credits and other economic policies benefit child health. 2022's Equity in You delved into different ways people could personally be an agent for change right where they are. And 2023's Pathways to Equity Reflect, Research, Respond, a three-part podcast series highlighted our history and research and how we and the audience can respond to inequity. This year, with Equity in Action, Children's Health Watch is taking a deep dive into different policies and topics of import during 2024 while providing ways people can take action to promote equity in their own communities. To kick things off, this first webinar, The Equity Considerations of Food is Medicine as a Healthcare Approach to Food Insecurity, will examine the concept of food is medicine and its potential to promote health equity. While many medical professionals agree that diet, food, and nutrition play a major role in disease prevention and management, The limitations of food is medicine interventions as an upstream solution to transform social conditions and improve population health are not clear. Thus, we have a roundtable of experts with us today to discuss the advantages of food as medicine as a preventative health measure and explore alternative and complementary approaches to improve population health and health equity at the policy and systems level. Moderated by our very own Rich Sheward, the Director of System Implementation Strategies at Children's HealthWatch. We promise a lively discussion with distinguished guest speakers. Dr. Diana Cutts, co-lead principal investigator in Minneapolis, site principal investigator at Children's HealthWatch, associate professor of pediatrics at University of Minnesota Medical School, and chief of pediatrics at Hennepin County Medical Center. Dr. Seth A. Berkowitz, author, general internist, primary care doctor, health researcher, and associate professor of medicine, University of North Carolina at Chapel Hill. And last but not least, Dr. Kofi Essel, the inaugural Food as Medicine Program Director at Elevance Health and Associate Professor of Medicine at the University of North Carolina at Chapel Hill School of Medicine. Now let's get into our discussion. Rich, I'll hand things off to you.
Thank you so much, Serlin, and I want to welcome our wonderful panelists for joining us today, and thank you all for joining us for this kickoff webinar for the 2024 Equity Series. I'm just going to say quickly, for those who have questions along the way, please feel free to type your questions into the Q&A box, and we will have plenty of time for folks to have their questions asked and answered. And to kick this discussion off, I'll start with Diana. Diana, you've been a pediatrician and researcher for enough time to see the evolution and really the formation of this food as medicine field. I'd love to hear your perspective on how it has evolved over time, and how did we get to where we are today?
Thanks so much, Rich. It's a pleasure to be here and to be a member of this panel. Thanks so much. You know, you're the oldest person on the panel when you're asked to give the history. So I'm just going to lean into that thought and say that, you know, I think it's hard to talk about this topic without referencing the quote given to Hippocrates, the father of Western medicine: "Let food be thy medicine and medicine be thy food." And I suspect many of us have printed that up on a PowerPoint and mentioned that in talks that we've given. When I did delve into it, I have to say that, you know, the records from 25 years ago may be limited, but apparently that quote is nowhere to be found in any of the 60 documented texts that have been attributed to Hippocrates. So we're not sure who really said it. But I'm going to put forward the suggestion that food as medicine began about 50 years ago with a program many of us are very familiar with, the WIC program. I think WIC in many ways fits all the categories. It checks all the boxes. It is a program that serves pregnant, postpartum, lactating women, infants and children, ages to up to age 5 who are at risk for nutritional deficiencies. And, you know, this was a program that was started in the early 70s. It provides food that are chosen for their health benefits. So we're talking fruits and vegetables, eggs, beans, dairy, so on and so forth. And the research has shown over 50 years now that it reduces anemia, it produces babies of longer gestation and higher birth rate, and so on. And furthermore, good to note, it serves nearly half of US-born babies. So, you know, this is the mother lode of food as medicine programs in many ways. I think the field, though, started to be viewed in different ways in the late 80s and 90s during the AIDS epidemic, when we saw really not a federal top-down food as medicine program, but a very grassroots effort to provide food to people who were living with HIV and AIDS. And this was a movement that really established locations across the United States. And eventually, many of these community-based programs came together nationally to form the Food is Medicine Coalition, this network of organizations providing medically tailored meals, typically delivered to the home, along with nutrition education and counseling to people with not just HIV/AIDS, but a growing number of chronic illnesses that now includes cancer, ALS, multiple sclerosis, congestive heart failure, chronic lung disease, end-stage renal disease, and others, I think, as determined by locality. So I think in many ways, this was the grassroots direction that we move towards where we are today. With more creativity and folks in this realm, we see the development of programs like Veggie RX or Food RX or other sort of prescription-based programs that again look at medically tailored meals for diabetes, high-risk pregnancy, two efforts that I personally have participated in, and many, many, many other applications. I would say as our timeline proceeds, we see now the innovation of integrating stronger community voices and participation and leadership from community participants in the programs, and communal kitchens and local farmers brought into it, community gardens, youth programs that are working in kitchens and agriculture. And I'm going to top it off with what I think is sort of the latest movement or latest part of this journey is the arrival of Medicaid in lieu of service funding. So this is funding that provides alternative services outside of the traditional medical Medicaid benefits. New guidance from CMS in just this January 2023 allows more flexibility in use, and we're seeing multiple pilots which support nutrition as well as housing, transportation, other services that are interventions for social determinants of health. So I think we're at a convergence, maybe an inflection point right now, that we're seeing multiple meanings of food as medicine or food is medicine. And I think we can say that it's a great opportunity right now to think new thoughts, challenge old schemas, weave together new ideas and approaches to this intersection of health and food in our lives. Thanks.
Thank you, Diana. Seth, I'll turn to you. You've been very influential in this field, and you've done some really seminal research, especially around medically tailored meals. We'd love to hear from you as far as your viewpoint on how things have evolved over time, and what your work has showed us all, and where you think we are today.
Yeah, sure. And thanks for the kind introduction. And similarly to Diana, happy to be with this audience today. It's an exciting event. I mean, so for me, so I'm I think I'm the non-pediatrician on the panel, but I'm a general internist and adult primary care doctor. And for me, I mean, I think the evolution has kind of gone sort of in a way that I hope things would. A lot of my interest in this field was sort of stemmed from being a primary care doctor, seeing the way that food insecurity and low access to healthy foods impacted people's health, and feeling like I just had very few tools to deal with that. And even as our sort of biomedical sophistication in terms of technology and pharmaceuticals and things like that increased, there's like some basics that we just weren't really able to do for people. And so one thing that I think has been nice to see is that, I think we do have more options now than we used to. We're not all the way there by any means. It's not the case that in any clinic in the country you can, address these issues if they come up readily. But I think there are real pathways for making that happen, and that has been a nice evolution over the past, say, 10 years or so, or something along those lines. And I think one things that we've learned from studies that I've worked on, studies that a lot of other people have worked on, is that there's real potential to use these types of programs for managing particular clinical conditions, treating or preventing certain diseases or certain outcomes in the right context. And so seeing that, sort of evidence-based grow has been really exciting.
Thanks, Seth. And Kofi, you have a history as a pediatrician, an educator, bringing this work to the next generations of physicians and professionals. And now you're the inaugural director of Food is Medicine for Elevance, which I think is a huge deal and maybe the dream job for many who have joined. But tell us about your journey in the space and what has led us to this moment in time.
Thank you, Rich, for that question. We've come a long way in this work. So currently my role, so I work at Elevance Health, as you mentioned. Elevance Health previously was known as Anthem, and it's a large payer. We serve over 47 million members around the country, commercial Medicaid, Medicare. And in my role as Food is Medicine Director, I get to do a lot of this great work that we've been doing for years, but sort of at a higher scale, really through a population health framework, which has been outstanding to be able to lead and move a lot of this work forward from this vantage point. I mentioned it's been a long journey because it really has. When I started in this space, I always tell people I was always interested in food and nutrition. And came into medical school not thinking that I could actually do any of this work because I was told that doctors don't do work in food and nutrition. After coming across a phenomenal fellowship program through the American Society for Nutrition in my first year of medical school, I realized that this could be a career for me. This could be something that I could spend more time doing because I saw other mentors doing work in this space. And so I kind of just went down that path. A lot of community health, a lot of teaching, a lot of integration in different systems, a lot of health equity work around food, and then just kept going, teaching more and doing more research and advocacy. Food insecurity actually came later on for me in my fourth year of medical school. It was the first time I actually heard the word food insecurity, which is sad. And none of my medical students would say that they waited till their fourth year now to hear about the term food insecurity. But that was my reality. And it wasn't that I didn't have my own experience, that I hadn't seen food insecurity. It's just I didn't know the term. I didn't know the language. Though the social drivers of health language was not as familiar as what we use today. And so for me, that was a really eye-opening experience. And I started doing a lot of work with advocacy. And Rich and I, we spent a lot of time on the road over the years, right? Going around teaching a lot of providers, students, how do you advocate? How do you screen and intervene to address food insecurity more effectively in clinical spaces? This is something that I did for many years. Before coming over to my role at Elevance Health, I actually was running a culinary medicine program at George Washington University, doing a lot of the teaching around this aspect of food and nutrition, something that I've been advocating for years to incorporate more into medical training, and finally having the chance to say, hey, this is important, this is how we can do it. And it was an amazing opportunity as well. So all of this kind of came together to where I am now, which has been an exciting journey all along.
That's great. Thank you all for sharing that. So Kofi, we'll stick with you and then turn to Seth, just to sort of set the context for the variety of people joining us today. How would you define food as medicine? So what is it exactly? And what are its limitations, or what are the ways in which food as medicine can or cannot address root causes, issues around equity and health disparities? So what are sort of the contextual factors around food as medicine that folks should know?
Sure, great question. So the way that we define food as medicine at Elevance Health is that food as medicine are strategies or interventions that work alongside healthcare, that give access to high quality, nutritious foods, focused primarily on prevention, management, or treatment of disease, right? So we're thinking about tools, how we can use food as a tool to prevent, manage, and treat disease by working alongside healthcare. These are critically important points that we think about. Typically, the angle that we often think through is a food insecurity lens, but as we evolve and think about terminology and complementary terminology, we think a lot about food insecurity, nutrition insecurity, right? The complement, and also diet-related chronic conditions as well, how we can use food as a tool to engage these topics. Typically, when people talk about food as medicine, they usually highlight the food as medicine pyramid, right? So the food as medicine pyramid is the language that people often use. The first pyramid that I'm familiar with was way back 2019, I believe, a group out of Massachusetts, actually with their Massachusetts state plan around food as medicine, they came up with this beautiful pyramid. The pyramid has evolved over the years, and there are maybe about 6 approaches that people typically use within the food as medicine framework. The first most common one, and I won't go into detail about each of them unless we want to, but first and foremost, people talk about medically tailored meals, right? So medically tailored meals. The next one is sort of this idea of medically tailored groceries, produce prescriptions, right? Fresh or frozen or canned produce, which can be quite powerful as well. We also think about federal nutrition programs, referring into these programs. I mentioned the WIC program, a dynamic food as medicine program that we love referring into, right? So other federal nutrition programs as well can be really powerful tools in improving health outcomes as well, working alongside healthcare. We also think about number 5, population and community level healthy food policies and programs. Are there big P or little p policies, public advocacy that we can be supporting that will transform health systems, that will transform food systems, that improves the health for members far and wide and patients far and wide? These are important tools, but also community level interventions as well. Our local food banks, our local food pantries and soup kitchens, our local FIMIC agency organizations, right? Our MTM organizations, and all the other phenomenal groups that are doing great work on the ground as CBOs and nonprofits. We cannot forget about them as an important piece of the food as medicine approach as well. And last but not least, number 6, an approach that I would highlight as a very important approach to food as medicine is also the idea of personalized, empathetic, person-centered nutrition counseling and education. This is also a really important thing. How can we meet individuals where they are and providing high quality education? You mentioned the piece about equity, which is an important aspect that we have to keep in mind. There are definitely barriers to what food as medicine can do. I don't think by any means we should think of food as a tool that really addresses the root causes of food insecurity, right? Food is a tool that can be used to help, to improve, to buffer food insecurity, but it's not solving root causes of food insecurity by any means. And we understand that. At Elevance Health, when we think about food as medicine, we're thinking about it baked into the concept of whole health, right? So we recognize that so much of the health outcomes for individuals are based on what's happening outside of the 4 walls of clinical spaces, more than what's going on in those 4 walls. What's going on in those 4 walls are important, yes, but they don't have the large weight of what's sort of creating those poor health outcomes in the long run as much. And we have to think about these other social drivers of health. So thinking about that is critically important. The way we think about it is through this concept of health equity by design. We have really important data we understand about patients and members across the country. How can we understand these inequities and these disparities and actually realize what's going on and be strategic and intentional about addressing them in a way that meets members where they are and sort of helps to reduce these inequities that we're seeing? That's a really important piece that we can see here. I have more to say, but let me pause and pass on to my colleagues to talk more about it.
Yeah, thanks, Kobe. I think that was great, and I completely agree with everything. I'm not going to reiterate, Kobe's definition of what food as medicine is, because I think he hit all the highlights, right? It's provision of food resources. It's for a specific clinical purpose, to prevent or treat some condition. There's usually some conjunction with the healthcare system, although that doesn't mean that the intervention is necessarily delivered by the healthcare system, but healthcare is kind of involved in some way. One thing that I do like to try to emphasize, though, when talking about food as medicine is, kind of talking about what it isn't, because I think there are a lot of very well-founded concerns about, sort of the potential for over-medicalization and things like that. So, food and nutrition are just sort of fundamental to the human experience overall, right? There's culture, there's family, there's tradition, we all need food to live and things like that. Food as medicine is a very small subset of all the ways that food affects human life. And you can even think of it as a small subset of what you might call population health nutrition, all of the ways that nutrition affects health. And food as medicine is just a small piece of that. And sometimes I like to understand that by way of analogy. So if you think of like exercise and physical activity, right, that's another just sort of fundamental basic part of human life. There are some situations, say a structured physical therapy program after a knee replacement or a cardiac rehabilitation program after a heart attack or something like that, where sort of health care and physical activity and exercise intersect, and those are great interventions for managing those specific clinical conditions. But that's just a small part of how physical activity and exercise affect our lives overall. And I sort of see food as medicine in the same way. There are food as medicine programs that might be great for specific clinical situations, but that doesn't mean that food as medicine is sort of the end all be all of all the ways that that nutrition can impact health. To the equity piece, I also just completely agree with Kofi there. I mean, so one of the ways that I think about health inequity as injustice that harms health, and we know that there are a lot of injustices out there, and they have harmed a lot of people's health. And so when that happens, having some kind of mitigation strategy, having some way to try to undo the damage as well as possible is important. That's an important clinical service that I think we can offer. We can try to improve people's health when they've say experienced food insecurity, which I consider experiencing food insecurity and injustice in the U.S. But I think we all also know that it would be better to not experience that in the first place. And no matter how good your mitigation approaches are, it's probably not going to be as good as just not having that happen. And food as medicine programs, I don't think really touch that other piece. That's really where I think the role of social policy plays in. I know we plan to talk about that a little bit more, so I'll stop there. But I think understanding sort of how food as medicine programs fit in to sort of the overall array of things that affect health in the U.S. is just an important piece.
Yeah, thank you both for setting that context, and to sort of continue with the equity through line. I think we all know that it's the provider, the medical institution, that is really sort of the nexus or the main power broker in the food as medicine relationship. They fund it themselves. They receive philanthropic support. They receive federal government support to initiate and lead these food as medicine interventions. A question that I'd like to ask that actually comes from our friends at the Corbin Hill Food Project, that have done a wonderful webinar last week, which we can link to, has an observation of this power dynamic. Is food as medicine a potential model where institutions define what is best for communities, and how do we avoid perpetuating inequities in this space? How do we initiate and lead food as medicine interventions that actually promote equity? Diana, let's hear from you first.
It's a tough question, and I think the comments we just heard really reflect some of the deeper thought about that. And I resonate with that concern. I think that from the outset of my involvement in taking care of children and all the various endeavors I've been involved in, including hospital-based food shelves or food packages or medically tailored meals, all of them, I think I struggle with, is this the right role for healthcare? Do I need to write a prescription for healthy food? Is that the societies that we're setting up? Will I be writing, prescriptions for lead-free water and clean air? To me, these are more societal, social concerns that need to really be considered outside as well as inside our systems of medical care. I think particularly at this point in history, where we're seeing that medical systems are so overextended, so financially stressed, losing workforce numbers, I think a more universal look at non-medicalized approaches has a place. Let's talk about a SNAP benefit that can actually pay the cost of a healthy diet. We're not there yet. Let's talk about increased child tax credits, other public policy. Is there a place to talk about more regulation of the food industry and the restaurant industry? Do Olive Garden and Denny's have a right that they can offer a 2,000 calorie dinner with 130 grams of fat on their menu? Is there a role for more nutritionally favorable policies in the food industry large? And, you know, how do we get in the community? Is there a future where we perhaps think about dietitians in every grocery store and farmers market, so that that access, that nutrition education, that involvement with choices, and that whole information, which honestly, Kofi, as you explained, has not been a strength in medical school. Let's be honest. It's coming, but it's coming late. And it's certainly, there are others who hold real expertise around this. Is there a way to better bring that into communities and to grow it within communities? I think too, this question gets a little bit tied with the question of who's paying. And Rich, you started to bring it up a little in your comments. Is this done through taxation and public policy? And what are the politics of that? Is it within private insurance? And what is their role and how are they playing it in the current moment? Is it philanthropy foundations where it's traditionally been? But even those foundations, I think, bring up issues of Walmart foundations funding programs and simultaneously not paying a living wage to its own employees. So I think there are a lot of very interesting and tangled dynamics in the discussion. And, you know, getting upstream to prevention needs to be a mantra. You know, we really, I think conceptually having an intervention that requires an admission ticket of having a disease or having food insecurity for that matter is a restrictive concept. And how do we make access universal to those who feel they have the need without requiring some admission ticket to it? So I think those are all important questions. Yeah, I'll leave it there and let others jump in.
I can go next, Seth, if that's okay. Diana, you brought up so many important points. A few things that I would love to build off of. Number one, I think the healthcare system is taxed, right? As a pediatrician, I serve many roles: social worker, community health worker, psychologist. You know, I do fluoride on teeth now, so I'm a dentist, right? So I do all these different things, right? So keep on adding more and more things. It becomes very difficult. It's challenging. I will say that interventions like food as medicine interventions in healthcare actually, from what I've seen, fights burnout more than adding more and more things on. Why? Because we're seeing these conditions. They're quite prevalent. If you start with adults, we see the risk or the rates of diet-related chronic conditions only going up. Even in children, we're seeing that as well. The question is, what do you do? So what do you do when you see this? Are we skipping over these evidence-based solutions of using food as a tool to intervene and go right to these other steps of medications and other things, which medications are incredibly effective and powerful, but a lot of families want to start with other tools as well. Do we believe in the power of food as a tool to improve health outcomes? And I think starting there is a very important piece. Should it be a part of healthcare? I think adding it to the conversation is incredibly important. Are physicians the gatekeepers to healthcare incorporating nutrition? I saw a dietitian comment in there, and I think it's important to highlight this. No, we should not be. right? We are working as a system, as a core system. We need to be able to know how to refer to our RD partners, our nutritionist partners, our community-based partners who are doing phenomenal work. But MDs need to be trained for a few important reasons. One in particular is so that we, as one of my colleagues says, do no harm. Because a lot of what we have done around this food and nutrition space is more harm than good, because we're bringing in our own lived experiences around food and nutrition, sharing it with others. And a lot of times it's quite stigmatizing and off-putting, right? Rather than meeting them where they are with evidence-based criteria, intervention, and support. Having food as a viable tool to do that really changes the system completely, reduces burnout, because now we have tools that we can connect families to when they're faced with these chronic conditions, food, nutrition, insecurity, and the list goes on and on. So I do think it plays a role. I think that realizing this, and the definition that I use is that you're working alongside healthcare, it doesn't give us it doesn't take away the responsibility, rather, for us to be working alongside community partners. One of the things that we often talk about is this idea of community clinical collaboratives. How are we collaborating with community partners and moving this work forward? Because healthcare can't do it by itself. But what if we were to do this in synergy and working together, right? So if we think of it that way versus healthcare doing everything, I think it changes the paradigm and how we may think about this as well. The last thing I would say here, I think about some of my partners on the ground who are CBOs, who are doing this work, who've been doing this work for years. We're building off of their successes, right? We're building off of these successes from community-based programs, from programs like WIC and SNAP and those kind of things as well, but programs even before those were even started. We're building off of their successes, and we're learning from them and implementing these things. But we still have to continue to work alongside partners, making sure that our community-based partners, key stakeholders, have a seat at the table, and we are responding with an iterative design to the things that they are requesting, they need, and then we can use this leverage, this new vantage point, because it is a vantage point, there's incredible momentum here. How can we use this leverage to improve health outcomes? And I think that those are things that we can do with it. So I have a very positive outlook around it. I think we can still do it, but we cannot, like you said, we cannot forget about the role of community. If we forget about that, we're just going to worsen inequities, and we don't want to do that. We should not want to do that.
Seth, anything you wanna add to that, or
I think hard to top those. I agree with all of them, all the points made.
Great. You know, we were just talking about sort of the role and position that healthcare plays. And we touched a bit on community, the importance of community. What I've heard others say that I think really resonates with folks is where we are today, in the sense that there's a real tight rope that we need to walk as a field, in the sense that on the one hand, we want to make sure we're supporting community-based organizations, nonprofits that are really embedded in the communities, arguably the most able and best to support community members. But on the other hand, there's a lot of interest and role and capability among for-profit entities that are in this space, like Instacart or Amazon, or large organizations that can really scale quickly and serve many more individuals and households than a small nonprofit in a neighborhood or one single city can do. So how do we walk that tightrope? And is there a right balance to strike? Maybe not, but I'd love to hear thoughts on that.
I mean, I'll just second that. I think it's a really tight, it's a fine line. It's hard to do. I mean, so fundamentally, I think a lot of the work of this field has been led by community-based organizations, and it would absolutely be the wrong thing if they get kind of boxed out or swamped as things scale. And I think there are real risks that any of the benefits, which have largely been seen when these interventions have been either delivered fully by, or at least in partnership with community-based organizations, may be difficult to replicate by organizations that came in a different way. So I do think there's some real risk there. We really need to pay attention to implementation if we do scale things. On the other hand, like, scaling is the way to get these interventions to more people, and so we need to kind of take that seriously. That doesn't mean, I think, just assuming that a large organization is going to be the one to scale with. It may be possible that we can grow some of these smaller organizations into ones that can serve more. And I've certainly had some personal experience in working with an organization that has expanded its scope and reach pretty dramatically during the time I've been working with them, not because of anything I've done, but just because they're responding to increased need, increased opportunity, and those kind of things. So I think those are important there. At the same time, there are some aspects of healthcare or other things where, we just sort of do this, right? We don't expect that every home nursing agency that delivers infusions at home or something like that is a small community-based organization. They are businesses, and possibly with appropriate regulation and everything else, that can be a way to make sure people get home nursing services that they need and whatnot. And so it's possible to imagine that this can be done well. But I do think there are a lot of things we need to pay pretty careful attention to, and make sure we don't have the unintended consequences of sort of losing some of the things that made these interventions as successful as they've been.
Yeah, I'll give a pause if anybody wants to add to what Seth had to say. Great. Well, Seth, let me keep it with you for a moment here. If folks don't know, you have a new book that just came out, and I've had the pleasure of reading through it, and I think everybody should read it. It's wonderful, and we'll make sure that we provide a link to it in the chat or follow up. But in your book, Equal Care, I think you do a really wonderful job of describing universalism versus residualism in terms of public policies. So if we're going to broaden our scope from individual interventions between community partners or providers and healthcare to the role of policy, public policy, what do you think is the relative balance between universalist policy versus residualist policy? And you can describe what those are, and how do they affect the need for interventions that are sort of outside the scope of that, like food as medicine interventions? Would more universalist policies reduce the need for residualist policies? So love to hear a bit from you about that. Thank you.
Yeah, thanks a lot, Rich, and thanks for the kind words. If when you do things like this, you kind of send stuff out there and you don't know whether it's going to resonate with people or not. So it's great to hear. It's good feedback on it. So yeah, so as you mentioned, so the book is called Equal Care. It's out now. You can get it on any online or a book retailer of your choice. And I really see it as kind of like that other piece of what I was talking about earlier. So a lot of my day-to-day work is in this kind of more clinically focused, within the healthcare system type of interventions that are meant to mitigate injustices after they occur. But the other part of that is that I think we need to be working in parallel for a policy environment in which these injustices aren't occurring in the first place. And so in the book, we talk a lot about, what policies we need to do that and how to set them up. And one of the key things that you highlighted is this distinction in policy orientation between what you might call universalism and residualism. So the idea of universalism is that we should design policies that are kind of first line policies. They're just the normal way to do things. Everybody uses them. And so a good example in the US would be like Medicare for health insurance coverage for people over 65, or maybe public school education. Like these are just kind of normal things that everyone does as the first line, rich or poor. There might be slight variations, but that's just the regular way to get your health insurance coverage if you're over 65, or the regular way to get your primary school education and those kind of things. The other approach is, what's sometimes called residualism. And this is the idea that you create programs, but you don't really mean for everyone to use them. You want people to use them only if they have needs that are left over or residual. That's where the term gets its thing, and can't be met in some other way, can't be met through, the market or other things there. And so those will be policies in the US like Medicaid or SNAP or TAMP. They're often means tested as a way to sort of prove you quote unquote really need it. These are better than not having the programs at all, for sure. They absolutely help people, and I'm not denigrating them in that sense. But they essentially kind of reinforce a type of social stratification where some people get things the normal way, and then some people need the safety net or the extra help, or there's something that hasn't gone well, and so we kind of need to step in. But our goal is for people to not really use them that much. They often become stigmatized programs in some ways, again, because of just sort of this way of building in that, like, well, this isn't like the main way that people should be getting their health care or getting their food dollars or those kinds of things. And so it becomes off-putting. It creates a sort of adversarial relationship sometimes between the people administering the program and the people who have the needs. We generally see that that take-up for eligibility is well less than 100%. So many people who may be eligible for benefits don't actually receive them through some combination of stigma and administrative burdens that are put in place to, again, sort of make sure this only goes to people who really deserve it, and all these other things there. And so fundamentally, I do think policy plays a big role in whether people need food as medicine type interventions overall. And in particular, I think more universalistic policies that anticipate the situations in which people might experience food insecurity. So, for example, having a household with young children who are obviously not out earning a living, but have consumption needs that need to be met, experiencing work-limiting disabilities, having older age, experiencing unemployment, all these things that create the situation that food insecurity can occur. Our policies could sort of insure people against them. This is sort of the social insurance idea. So, a child allowance or child benefit like the 2021 expanded child tax credit, or probably our most successful anti-poverty program in the U.S., Social Security's old age and survivor insurance, the Social Security checks. These things can, recognize, hey, these are situations where people often have problems. Why don't we just proactively try to prevent that? That I think would work a lot better and prevent the need for people to, need a food as medicine program or something like that. And so the book talks a lot about, why, giving that justification, but also kind of like how to actually do it. How do we finance it? How do you run these programs? How does it all fit together? So it's not, there's not one silver bullet program that's going to solve all our problems, but how to create a set of programs that produce health for everybody, and in doing so produce health equality or health equity.
Thank you very much. So I'm going to ask one more prepared question, and then we've got a lot of great questions in the Q&A, which I'll turn to. So moving from policy to people, we've talked a little bit about the different populations that stand to really benefit from food as medicine interventions. But Kofi, and then I'd love to hear from Diana, why are children, why is the pediatric population such an important one to focus on? Do they often get forgotten in some of these discussions? And granted, there's a bit of a bias here coming from Children's HealthWatch, but enlighten us.
You're biased. I'm biased too as a pediatrician, right? So, getting to see on a day-to-day basis the role of food, of social drivers of health on children and their future is something, when you see it, you can't unsee it, right? So it's one of those things that recognizing the importance of prevention is a powerful tool. Diana, you mentioned it yourself, right? So when we think about the cost burden of diet-related chronic conditions on children, or even food insecurity on children, sometimes we're not seeing that children are carrying this huge cost burden, right? They don't carry the huge cost burden. They're not carrying this huge burden of disease even as compared to adults. They don't get the same attention and efforts as we may see. In addition, when you're looking at the analyses, the studies that are across the board, the pediatric focused food as medicine studies are a little bit further behind. Seth, we got to bring your work over to the pediatric space as well in the future, right? So we need some more studies. These studies are coming. They're on the verge. You're seeing them getting stronger and stronger, more RCTs, more robust studies. And I think we're going to be able to start making some of those stronger arguments sooner than later. But at the end of the day, right now, we don't have the data to show the effectiveness of food as medicine as a tool to improve health outcomes, reduce cost savings in children in pediatric settings. Unless we're talking about WIC, which there's some great evidence there, and WIC is probably the #1 food as medicine program for children. But in general, I think we have to think about children because we have to think about how these diseases, how these settings, these environments are going to influence the next generation of adults as well. And if we don't intercede now, what are we doing? We're just worsening future outcomes. So how can we think about this in a different way? And that's, I think, critically important, and really highlighting, Seth, the work that you're writing about and that you've written about in your book as well. I think for pediatrics, we can easily think about food insecurity, right? How we can engage food and nutrition insecurity. We can think about a scholastic achievement and how we engage this topic as well. And of course, prevention. That is the angle that I think we can think more through. And I think it's critically important. If we want to improve the trajectory of the next generation, we have to think about the children in general.
Well said, Kofi. Thank you. You know, I think I would just add, as a pediatrician, you know, we know biologically children are most vulnerable in terms of having poor nutrition and the associations of poor nutrition with development and brain health. And so I think taking a pediatric lens and seeing, one, the vulnerability of children, I think two, the demographics of children, which show us that children are the population that carry the heaviest burden of poverty in this country, and that children are the population that show us the greatest diversity. And with that diversity, we see heightened inequity. So I think both for these reasons of vulnerability and demographics, that we've got to get to where Kofi is suggesting we need to go, which is a greater focus on children in these kinds of efforts.
Thank you both. So there's a really interesting question in the Q&A about what is the role of health departments, or what I would call, the agencies and institutions that are regulating the restaurant industry. There's a comment in the chat about marketing and advertising from the food industry. I feel like there's only so much within our control from the perspective of healthcare, from the perspective of the amazing work done by agencies addressing food as medicine issues. But what about those bigger forces that are maybe that feel out of our control? What regulation, what ways can we tackle the food environment? Is that a natural outgrowth of our focus and, training and concern?
I'll start it. There's clearly predatory marketing that is happening, and we've seen the data time and time again, and it influences behaviors. If it didn't influence behaviors, it wouldn't be happening. So we know that these are huge efforts that are being done to change what we do, how we engage with food. Maybe it's not as maladaptive or as predatory in their approach. Maybe the thought process is not there, but the results are clearly, it appears to be predatory. I would say that, Diana, you mentioned it. Food as medicine through this angle is just one approach. We have to think about how we step outside of these four walls and use the tools of advocacy to transform the systems that lead to these poor health outcomes as well. We cannot just think downstream. There has to be more and more upstream population approaches, and stepping outside the four walls, especially, as we're talking as providers as well, the voice matters. Making sure that the voice of our patients are heard. These are things that we cannot allow to rest. We have to bring these voices to the forefront as well.
I totally agree with that, and I guess sorry to have a call back to the book or whatever, but one of the things I really try to advocate for in the book is sort of this idea of having democratic like more democracy, basically. So more putting us all in positions of equality with each other, where sort of all our voices count and things like that. And I do think some of the things that you described, Rich, that might fall under the framework that sometimes uses of commercial determinants of health, so ways that commercial enterprises through their actions and those things impact health outcomes. Part of what enables that is, sort of regulatory capture and an outsized ability to influence public policy that comes from concentrations of resources and wealth and those kinds of things. And so a potential way to combat that is to sort of re-democratize the relations that we have with each other, where people have the material conditions that enable them to really be active participants in government, and sort of not have the situation where a few organizations with lots of resources essentially get to dictate policy with all the consequences on health and other things that come from that.
Both very well said. Well said. There are two other questions in the chat, which I think will feed nicely into what I'm going to ask each of you. We'll go Diana and Seth, and then Kofi to sort of share your final remarks, maybe your call to action around advocacy. So what should people be thinking about when it comes to advocacy? Does this relate to access for SNAP benefits or the improvement in federal policies from what we're seeing in the food as medicine space, but also equity considerations that maybe we haven't yet fully tackled, rural access, in relation to urban access to these programs. So what are the advocacy, what are the equity concerns or opportunities? What's your call to action? We'll go Diana, Seth, and then Kofi. And then unfortunately, we'll have to round out and close off this discussion.
Wow. Okay. I think we've mentioned some of them along the way. I think, one way in which medical systems, I think, are well positioned to be helpful is to leverage our electronic systems to do more auto enrollment. Every pregnant woman who qualifies should, as they register to get care, they should just automatically be enrolled in WIC. There shouldn't be a delivery of an eligible mom who isn't already enrolled, and that will bring the baby into enrollment. I think, so I do think there are ways in which we can be powerful in leveraging the built system. And then I think the policies we've alluded to, I'm not going to hash them here. One thing I'll say, I'm going to make 2 points because quickly. One thing I would say is, I think we all on this call have authored research that is moving the field along, and I couldn't be prouder of that. But sometimes I want to say, like, when do we get to author the last article that seals the deal? What is the bar of concept of proof that we need to reach that seems so believable, that healthy food means health and access to it enables and allows health to achieve its potential? Like, what is that bar of that we need to get to where we can say this is the last article? I hope somebody on this call authors it. And then the other point I'll make is, I think conceptually, as we think about nutrition, we think about it's a clinical concept in so many ways. It's almost mathematical. It's calories and protein and micronutrients. And maybe there in the future, we'll have the opportunity to think about concepts more broadly, like nurturing and nourishment, which really, I think, bring in the opportunity to enrich sort of not just the body, but the spirit. And I hope that'll be our next evolution. Thanks.
I try to stay very brief, but so I really appreciate you highlighting the multiple dimensions of inequality that are at play here. And I think, one way to sort of unite all of these is to think about them as all kind of forms of what you might call relational inequality. So the fact that we have a hierarchy of social standing or social status that sort of advantages some people and disadvantages other people. And fundamentally, I think what you need then is to sort of build institutions that put people back in a relationship of equality with each other. And the way to do that, as maybe uncongenial to me or people in healthcare as it is to organize. It's to work in large groups with other people, boring things like going to meetings and showing up and whatnot. I'm a clinician. I want to be able to do something, right there and then, and do this on an individual level with the person in front of me. But fundamentally, if you want to build the institutions of equality, it has to be done through, organization with a lot of other people.
And I don't really have much to add, but 2 things I guess I can. Don't forget about the kids, right? That's great. And then also, I was thinking about, Diana, as you were talking, I was thinking about nutrients in food, right? As you were talking about nutrients, like nutrients are so great, but let's talk more about food. And not only food as health, but recognizing the multitude or the multidimensional role that food plays, a personalized role that food plays in our lives. And recognizing that means that in our interventions and our approaches, we got to get outside of these very rigid approaches and how we talk about food, engage food with families. And I think that's an important piece to not forget about, because if we don't, like I mentioned before, with other aspects, we can worsen inequities by ruining or demonizing people's foods that are part of nutrition and life and health and joy and culture and tradition and all these experiences as well. So just let's not forget about food as well.
Well, Kofi, Seth, and Diana, thank you so much for joining us this afternoon. This has been an amazing conversation. I'm going to turn things over to my colleague, Serlin, to bring us home, and we'll say thank you to everyone for attending.
Wow, thanks, Rich. And what a great and inspiring discussion. Thanks to Rich for your excellent moderation. And of course, to our wonderful speakers, Dr. Diana Cutts, Dr. Kofi Essel, and Dr. Seth Berkowitz. Last but not least, thanks to all of you who attended today's webinar. If you enjoyed this discussion, we have 2 more webinars on the horizon. One will be on immigration and the other will be focused on guaranteed basic income. So sign up for our newsletter and our mailing list at www.childrenshealthwatch.org to get the latest details on those, or friend us on X, aka Twitter, Facebook, Instagram, and LinkedIn. Thanks again so much, everyone, and have a lovely rest of your day.